than in the general population with a prevalence of 7 to 8%. In a population-based study in Great Britain, rate of any psychiatric disorder with 37% among children with diabetes in comparison to 11% children with diabetes and 9% among the controls. So it's a heavily loaded. Early onset epilepsy is an important contributor of comorbidities. Animal models suggest that seizures in the immature brain causes altered brain network and poor cognition. When examining children with established epilepsy, many studies have shown earlier age of seizure onset to be correlated with lower IQ, poor academic performance and developmental delay. Major mediators of neurobehavioral comorbidities: altered brain development in children with epilepsy, altered accelerated brain aging, increasing vulnerability to seizure-induced cognitive deficits, underlying brain disorders such as malformations of cortical development and traumatic brain injury have increased risk, longer epilepsy duration, multiple epileptiform discharges, and seizure medication itself. Now, what are the psychiatric comorbidities? Mood disorders, suicide, anxiety disorders, psychosis, BNS, personality disorders, cognitive abnormalities, other comorbidities like ADHD, aggression, and hyposexuality. Mood disorders, most prevalent neuropsychiatric disorders in the epilepsy. Depression among patients with epilepsy ranges from 20 to 55% in patients with recurrent seizures and 3 to 9% in patients with a controlled epilepsy. Studies focusing on depression in children with epilepsy found depression rates of amongst 23% in 8 to 18 years of age group with new onset of epilepsy. Mood disorders like major depressive disorders, dysthymic disorders, adjustment disorders, and depressive episodes of bipolar disorder. Most patients with mood disorders and epilepsy have dysthymia, that's a low mood. Suicide. Risk of completed suicide in epilepsy patients is 4 to 5 times greater than amongst the non-epileptic population. With complex partial seizures of temporal origin have 25 times higher. Depression and cognitive impairment seems to be the risk factor for suicidality in epilepsy. Contributors to successful suicide includes paranoid hallucinations and occipital ictal command hallucination to commit suicide. Anxiety prevalence rate is 19 to 60%. The type of disorders with increased incidence in epilepsy patients include panic disorders, generalized anxiety disorders, phobias, obsessive compulsive disorders. Having epilepsy is associated with a large number of threats, including the unpredictability of the seizures, the feeling of loss of control, the risk of ictal injury or even death, and negative social effects which further increases anxiety in these patients. Psychosis 6 to 12 times more common in people with epilepsy than general population. Incidence of psychosis is 2% to 6%. Among the most systemic description of psychosis is the categorization based on temporal relationship of the psychosis to the ictus, ictal psychosis, post-ictal psychosis, inter-ictal psychosis. BNS are involuntary psychotically induced spells that mimic many epileptic behaviors. Up to 30% of the patients with epilepsy are affected by non-epileptic seizures. Differentiating epileptic seizures from non-epileptic seizures can be difficult based on history alone. Video EEG monitoring is the gold standard. The most helpful differentiation feature may be an ictal duration of 2 minutes or more. Non-epileptic seizures usually occur in the presence of a witness, can often be induced with injections, hypnosis or suggestion, poorly responsive to anti-epileptic medications, Ultimately, the differentiation may require continuous video EEG monitoring. Personality disorders. Prevalence rate of personality disorders are 18%. They are borderline histrionic and dependent disorders. The most common personality disorder is the borderline personality. Personality profiles of patients with epilepsy can be explained by a complex combination of the effects of dealing with a chronic illness, being epileptic, anti-epileptic drugs, and temporal lobe pathology. Cognition. Many studies indicate an increased prevalence of cognitive abnormalities in children with epilepsy. IQ less than 70 in 27% children with epilepsy. Noted impaired non-verbal intelligence in 47%, while 3% is a healthy controls. Impaired executive function on 7 of 8 tests in children with epilepsy. Hyposexuality. Patients with epilepsy tend to be hyposexual. Men and women experience disturbances of sexual arousal and a lower sexual drive. Men have an increased risk of erectile dysfunction, suggesting a neurophysiological component, and studies of sex hormones suggest the possibility of a subclinical hypogonadism. There can be undesirable effects on sexual performance of anti-epileptic medication, including erectile dysfunction, decreased sexual desire, retrograde ejaculation, and altered semen quality. It's a bidirectional relationship in various studies that increased risk of unprovoked seizure up to 2 years before and 2 years after the psychiatric diagnosis that there is epilepsy, or increased risk of epilepsy in patients with schizophrenics. These data suggest either a possible bidirectional relationship between these two disorders or the presence of common pathogenic mechanisms that facilitate the occurrence of one in the presence of the other. The affective disorders more common in temporal lobe epilepsy. It's a limbic structure located in the temporal lobe. On one side that covers with a regulation of pleasure and mood. On the other side it generates the seizure. So due to this dual function of the limbic system, numerous studies have addressed the relationship between the temporal lobe epilepsy and affective disorders. The important part is the treatment strategies. In the treatment of psychiatrically disturbed epileptic patients, we need to address certain issues. Which AED to choose from, which psychotropic to choose from, what else can be done. Which AED to choose from, carbamazepine and valproate have significant anti-manic and modest antidepressant properties. They have an efficacy in the long-term prophylaxis of manic episodes. Carbamazepine and valproate may also aggravate some discontrolled, aggressive behavior in brain-injured patients. Lamotrigine is the only antiepileptic that has a well-established efficacy in preventing recurrence of depressive episodes in bipolar disorder. Clonazepam, in addition to the anxiolytic properties, can serve as a supplement to other anti-manic therapies. Even at therapeutic levels, barbiturate may need discontinuation because of drug-induced depression, suicidal ideation, sedation, psychomotor slowing, and paradoxical hyperactivity in the very young and very old person. Levetiracetam may cause irritability and aggression. Vigabatrin may precipitate depression. Gabapentin and pregabalin also decreases anxiety and improve general well-being in some epilepsy patients. Now this is a chart. Almost every anti-epileptics have got all the psychiatric issues, and particularly we should care for that, and every time we should ask also barbiturates, carbamazepine, ethosuximide, felbamate, gabapentin, lamotrigine, levetiracetam, phenytoin, tigabalin, topiramate, valproate, vigabatrin, zonisamide. Now, next important part is which psychotropic to be chosen from. The principle of choosing antidepressant will be based on adverse effect and tolerability of the patients. Antidepressant can alleviate both anxiety and mood symptoms at the same time. The most concerned issue for antidepressants in epilepsy is the seizure threshold lowering property. A small number, up to 15% of the interictal psychosis resolves without any treatment, but a majority of patients requires antipsychotics. Psychotropics and their seizure threshold, lowering threshold, high is a olanzapine, quetiapine, thyroidazine. There's a high seizure threshold. Moderate, but we are interested in the low one. And low one is a haloperidol, risperidone, aripiprazole. These are the three compounds which commonly uses. They have got a low threshold for the epileptics. Regarding antidepressant, select SSRI and SNRI are the best one. According to their better tolerability profile, SSRI and SNRI can be given as first-line antidepressant in patients with epilepsy. SSRI may be more suitable in patients with depressive disorders associated with comorbid anxiety disorders. SNRI may be more beneficial in patients with depressive disorders with psychomotor retardation, fatigue and cognitive slowness. First line SSRI are fluoxetine, sertraline, escitalopram. SNRIs are venlafaxine and duloxetine. Second line antidepressants are the amitriptyline, nortriptyline, imipramine, clomipramine. Now, barriers to assess mental health care. Barriers are the misconception that it is normal to feel anxious and or depressed if you have epilepsy. Potential solutions are the information leaflets about psychiatric disorders available for people and to be given in the clinic routinely. Another misconception is that chronic nature of the epilepsy, stigma towards mental health problem, which is also, so the double stigma is there, to routinely discuss about the psychiatric problems during the clinical consultation. Economic barriers and the lack of the resources. Well-defined clinical pathway to access mental health care depending on resources. Telemedicine is the answer. Lack of knowledge about the management of psychiatric disorders and the use of psychotropic drugs to implement routine use of screening instruments in clinical practice. Now, treatment strategy: screen for the presence of mood and anxiety disorders at every visit. Emergence of depressive and anxiety features should not be ignored. Possibility of weight gain and impaired glycemia control must be kept in mind while selecting the antidepressant and antipsychotic drugs. It is preferable to use drugs in combination with psychotherapeutic intervention. Milder forms of the depression and anxiety, especially in children, adolescents, and pregnant females, can be managed by psychotherapeutic interventions such as cognitive behavioral therapy, motivational therapy, problem-solving therapy. What else can be done? We should also implement behavior changes with mind gym, which involves training the mind to maintain the balance. Now, these are the meditation technique, deep breathing technique, yoga technique, relaxation therapies like Yog Nidra. Progressive muscular relaxation can help in reshaping the mind balance. Learning new skills or developing a new hobby to keep your mind active. Make efforts to go out, socialize with family and friends almost once in a week, which involves so many persons in day-to-day life also. And last, if not able to say and you have got a less time, then ask him to do 15 minutes reverse walking 2 times in a day. 15 minutes reverse walking 2 times in a day. Last, epilepsy is more than seizure. Epilepsy is a complex neurological condition that extends beyond seizures, often involving psychiatric comorbidity. Psychiatric disorders are highly prevalent among epileptic patients, impacting their overall well-being. Bidirectional relationship, there is a bidirectional relationship between epilepsy and psychiatric disorders. Diagnostic challenges, psychiatric disorders in epilepsy patient can be challenging due to overlapping symptoms and medication side effects. Quality of life impact. Psychiatric comorbidities significantly affects the quality of life for epilepsy patients, affecting their social and occupational aspects. Integrated treatment requires treatment should be integrated, addressing both epilepsy and psychiatric disorders with tailored medication, psychotherapy, and lifestyle adjustment. Support system including family, friends, and support groups play a crucial role in the well-being of the family epilepsy patient. Future research, ongoing research in this field holds promise for better understanding and management of the mild epilepsy connections. Thanks for the time.
Any questions to sir?
So any relation with mental retardation also with epilepsy?
Yes, the second point, of course, we have noted in the adults, as this epilepsy patient with psychiatric dysmotility, there is a low IQ if the longer duration of the epilepsy is there. Cognition effect is involved because in adults the cognition, and in children it's a 27% they have noted in children with epilepsy. Cognition impairment. Executive functions are also out. So altogether, one is, here is a epilepsy. Another part is a anti-epileptic drugs. That's why they have created the thing whether 1 or 2 seizures to be treated or not. Because benefit lies and the risk lies. Altogether in every anti-epileptic, everybody knows, then there are side effects.
I have put a few children with mental retardation on anti-epileptic drugs and they have improved to some extent. And post-COVID, we have been using anti-epileptics like valparin routinely to an extent that people were sleepless and they have sleep talking or even sleep startle. And
that you are taking the advantage of that carbamazepine and the valproate properties, which itself has got a anti-manic properties. They are mood disorders there, and commonly it is being used in 250 mg BD as a mood regulator, like a stabilizer. In you see, in every psychiatric prescription, you'll see that commonly they are doing that 250 mg sodium valproate BD once in a while because that slide shows.
I would feel first we should put them on sodium valproate, all psychiatric patients and retardation
that's
patients.
one thing, but putting them should not put in the childbearing age group.
That's true.
That may be the...
For depression, they use a mechanism called sleep deprivation. But sleep deprivation can aggravate the epilepsy.
So it's a psychiatry... so I say that everything can be there.
Okay, and what is your take on magnesium and vitamin supplements and improving the microcirculation with ecosprin and clopidogrel? And why hypersexuality is not a presentation by seizures?
So you'll have to ask in the clinic.
No,
You'll see that
you said hyposexuality, but why hypersexuality is not a presentation?
Hypersexuality can be the presentation of the psychiatric disorders.
Can't it be with epilepsy?
Don't think so. And with the epileptics are there, usually the hyposexual. They have got a less desire, so many side effects are there. But if they have got a hypersexuality, kindly evaluate from the psychiatric point of view. It may be that they are developing the psychosis.
And one limitation of EEG is the deeper circuits and low voltages can't be, recorded. MEG is better for recording.
Sir, here I notice only one thing about that multiple epileptic discharges are one of the side effects.
Side effects of?
Multiple foci in the brain. Like in the EEG, we are recording the frontal lobe, temporal lobe, and occipital lobe, etc. all the way. So that has got a poor prognosis. And they are commonly seen, they involve the psychiatric disturbances also.
No, what I was asking is, EEG might not pick up the electrical abnormality in psychiatric patients.
No.
Should we ask for a MEG in all those psychiatric patients to rule out? Because
Yes.
many might not be accepting the anti-epileptic medicines.
The best thing is this for the psychiatrist to evaluate the psychiatric things is an interview on the basis of the history, and you will have to read the faces. This is the best thing. Whatever code you apply, but it's a psychiatrist as a clinician, he sees that when he is entering, what is his voltage when he is coming up? What type of the things he are doing when he was waiting? Just see on the CCTV. There's so many things, because psychiatry is altogether as a history, observation.
What is your observation about risperidone-induced cardiac deaths and autoimmune diseases? Okay. I advise my patients karma therapy, therapy for about their life, past life. I mean, in the events in the past life, the emotions and how to deal with them and how to cleanse it.
Anyway, you involve the time with the patient. That is that's somewhat the combined therapy, psychotherapy, whatever the things. If you involve the time, then you induces the somewhat the psychotherapy. This is all. Otherwise, though, if you are busy and say that he is asking multiple questions, then ask him to do the 15 minutes reverse walking. Altogether, he is going to forget.
What is the philosophy, I mean, physiology and this thing behind the reverse walking?
Because you'll have to.
You have to think
You
to walk.
You himself.
You cannot walk. It is not a program.
You himself do. There is a lot of the concentration involved. This is the psychotherapy.
See, the gait we are trained to walk forward. When you want to walk backwards, you have to think. Your mind will get
You'll
distracted.
have to think. If you are thinking in the other way, then you may fall down.
Should we insist on a neurology opinion of all psychiatric patients, or putting all psychiatric patients on
Sir,
the
it's so many times the problem is neurologist sees the psychiatry patients and psychiatrist sees the neurology patients, because it's a bidirectional relationship. And you can very well see in a epileptic patients, when the recurrent seizures are there, more than 50% they suffer with a depression, and 10% they are with the psychotic things. And we usually observe not the 10%, almost after the 6 or 7 years, many more are having a psychotic.
So during COVID infection, there was a patient with
We are
seizures.
reaching that time.
Last question.
So,
In one patient, we had to put 4 anti-epileptic drugs to control the seizures in them. So, and even psychosis is high after COVID. What is your take on that? After COVID infection and injections?
see, basically, everything can be associated with COVID. Only thing we don't know how it was, because we started looking very closely after the COVID everything. So we should have a data compared pre-COVID and see now MI, they are all shouting the MI. Patients are lifestyle changes are not. See, our population is so much. No, don't get me wrong. Our population is billion. So the percentage of, even you say 1%, it will be 100,000. So that much of MI we will find. So, but that may not be true. So we don't have a pre-COVID and post-COVID data. I think we will not discuss that further here. Thank you, sir. Thank you very much. I think the only main take-home message, all person with epilepsy who comes to your OPD, apart from writing the prescription, knowing about the seizure, please ask, do they have any psychiatry? If you manage it, their quality of life will be better. That is, I think, the sir's main take-home message. Thank you, sir. Thank you.